Hello, I'm Erin, Cox physiotherapist. Right now we're going to talk about wrist arthrokinematics. For that, I'll just share the screen again. So arthrokinematics, don't forget that is talking about joint surfaces. So we'll look at what happens in full wrist range of motion requires normal mobility between all the carpal bones. The individual joints are stable when under tension and in alignment with each other. So just to review, we have Big Daddy, the capitate in the middle, which is convex all the way around. And then the proximal row on the of carpal bones on the radius and ulna and the TFCC is going to be convex. And then your hamate on this side is going to be convex on your triquetrium. And if we go a little further, the fourth and fifth are planar or convex also. But on the radial side, the trapezium and trapezoid are going to be concave on convex. So in flexion, what happens? So we have a dorsal glide of the proximal row of the TFCC on the TFCC and the radius. So the proximal carpal row will glide dorsally because it's convex. And the dorsal glide of the hamate and capitate on the proximal row because they are also convex. And then a palmar glide of the trapezium and trapezoid on the scaphoid to accomplish flexion. Extension will be the opposite. So the proximal row will be a palmar glide. The hamate and capitate will be a palmar glide on the proximal row. But on the radial side, the trapezium and trapezoid will be a dorsal glide for extension. Radial deviation. So radial deviation, so the proximal row, if we're going to move toward the radial side, the proximal row being convex is going to slide over or glide ulnarly on the radius and TFCC. Now the scaphoid glides ulnarly, and to accommodate, remember we said the ulnar side will do a will be a little more stable in this case because of radial deviation, but on the radial side, this is where there's an extension, like when we throw our dart. So the scaphoid will glide ulnarly, but it is convex on concave surface of the radius, so it will be a palmar glide to help us do radial deviation. And then the trapezium and trapezoid are going to be a dorsal glide because they're concave on convex. And then they also roll over the capitate as well to help with the associated extension. So they're going to do a dorsal glide. And if you just see that this part explained in your notes, when they talk about the scaphoid shortening, obviously it's a bone, it doesn't shorten, but it'll appear more horizontal on an X-ray. And then you get this line here between the third metacarpal, the capitate, and the lunate. They should all show up in a line. In the ulnar deviation, then the opposite happens, so that proximal row, if I want to do ulnar, will glide toward the radial side. The scaphoid also glides radially, but then it's a dorsal glide to go with a flexion because the scaphoid is convex on concave. And then the trapezium and trapezoid, to facilitate the flexion that goes with the ulnar deviation, will be a palmar glide, and then it will also do some folding. So in radial deviation, it's extension and some fanning, which is why when I said you look at the longitudinal rows, if you do an extension, the trapezoid and the scaphoid will roll backwards over the capitate. But if we do ulnar deviation, which is flexion, then the trapezoid will also go palmarly relative to the capitate to facilitate folding, and the trapezium and trapezoid go palmarily on the scaphoid to facilitate the flexion component in ulnar deviation. And again, here we see this in ulnar deviation. The lunate now only articulates with the radius, and it looks like the scaphoid is taller, but really now we can just see it more exposed in a radiographical imaging. The lunate and the capitate are now not lined up in ulnar deviation. So again, fanning and folding using the anatomical axis, the palmar glide and internal rotation of the lateral side of the hand. So if you're like Oscar is here in the anatomical position, okay, so that thumb is facing outwards. And now we're going to look at fanning and folding. So if you looked at and stood up yourself in an anatomical position, your hands would be by your side and the palms facing forward. So if I were to turn my shoulder internally rotating or externally rotating, think of that the rotation also of the fingers on the lateral side of that middle column are also going to do an internal rotation for folding, and the medial side is going to do an external rotation in order to be able to fold. And conversely, if I want to supinate and open my hand or fanning, then around the middle column, the lateral part of my hand will do an external rotation, and the medial part of my hand will do a medial rotation, and that is relative to the axis of the body. So just to note that when we talked and we saw it in the hand and we talk about ab and adduction, we're referring to adding to the middle column or abducting or away from the middle column. But for these fanning and folding, we're referring to the axis of the body. Functional wrist range of motion, full strength with pinch and grasp is possible from mid-extension through to neutral. Flexion impairs strength significantly by altering the muscular tension relationships. It's harder to pick something up like this than like this. Many functional wrist tasks require minimal wrist motion. So most ADLs, we only need about 30 degrees of extension, 10 degrees radial deviation, 15 degrees of ulnar deviation, and only 5 degrees of flexion. So we want to at least look at getting minimally this when we're treating our patients to acquire functional ADLs. That's all, folks.